Welcome to the Cleveland Clinic South Pointe Orthopedic Surgical Residency educational video series. This series was created for educational purposes designed to aid in patient care and teaching proper steps and techniques for commonly completed bedside orthopedic skills and procedures. In the setting of either a native or prosthetic posterior hip dislocation, a classic presentation is generally found of slight hip and knee flexion, as well as generalized internal rotation of the lower extremity on the affected side. Once adequate sedation has been provided, it is important to prepare for your post-reduction steps, and thus placing the X-ray plate beneath the patient prior to reduction can be of benefit. Once this is completed, it is critical to have an assistant or multiple assistants present to aid in stabilization of the patient's hips, as shown, as a counter to your reduction maneuver. Note that proper hand placement, as shown here, is with either hand over the anterior superior iliac spine of the patient's hips. At this point, you should position yourself for a reduction attempt. This most often involves positioning yourself above the patient as shown, while controlling the leg from behind the ipsilateral knee. This allows adequate positioning for necessary hyperflexion as demonstrated. The knee should be directed towards the contralateral shoulder as this is performed in an adduction vector. This allows for cup or acetabulum clearance, and after successful reduction, the leg should be gently lowered to the bed with generalized external rotation and abduction. In contrast to a posterior hip dislocation, the leg is classically externally rotated in an anterior dislocation. As such, the reduction technique involves inline traction, internal rotation, and adduction as shown. In certain cases, it can be of benefit to add an abduction force proximally from medial to lateral by an assistant to aid in cup or acetabulum clearance. In both the anterior and posterior dislocation cases, a palpable clunk is often felt or heard when the reduction maneuver is successful. In either scenario, it may be of benefit to provide inline traction or to ski on the affected side, as this can relieve tension on the spasming musculature as supplies and teams are being prepared. And finally, once the hip has been successfully reduced and final X-ray films taken, a neurovascular check along with leg lengths should be routinely completed. We thank you for viewing this segment of the South Pointe Orthopedic Surgery Residency Educational Series. We hope this video was beneficial and that you will utilize other videos from our series, as well as the correlating PowerPoint slideshows that expand upon each of the respective topics.